honored and humbled to be here in the presence of all these people who are so much more expert on these things. Our daughter, who is now a physician, pointed out to me that PhD is Greek for a doctor who cannot help you. But we have Mark McClellan, who has a PhD, and he can help you, because on the way to getting the PhD, I guess in his spare time, he got an MD degree. Where's Mark? There you are. James Trussell is a demographer. He knows about demography. I just know that people are getting older because basically from introspection. I don't know anything about ethics because I'm an economist. I know not much about genomics. I'm here to learn. And with health information, I still have trouble. I kid you not. I can get the printer started, but you ever tried to stop it? The other day I printed out the Charge Master of California Hospitals, 275 pages, 20,000 items on it, and I didn't know how to stop it. So I hope somebody here will teach me that. So I'm going to talk by what was on this program. I guess Lee put it on here, trends in global healthcare, or really global trends in healthcare, the way I think about it. Talk a little bit about that and then sort of end up with what the role of information will have to be. First of all, this is a growth industry, healthcare. It's one of the finest industry. I mean, I wouldn't want to be in the United States automobile industry, but healthcare is really it, because there is a very strong relationship between health spending and GDP. We economists call it elasticity, mainly so no one understands what we're talking about, but it's really the sensitivity of health spending toward GDP growth. And if that ratio is, say, 1.3, it means on average, health spending tends to rise 13% every time GDP rises by 10%. And healthcare, when you plot it, this is from the World Bank publication. They literally got 191 data points in here. This was an old one. I haven't seen one like it, so I used it because it hasn't changed much. There's a very tight correlation between income, GDP, and healthcare. So as global health GDP grows, this industry is going to grow even faster. If you look at just the OECD countries, I do have that equation, and you see here 32 OECD countries. The 6,000 is the United States. As you know, we have the best health system in the world. Therefore, Harold is smirking. But we spend a lot of money. But look at this little coefficient. 1.3 is indeed the income elasticity across the OECD. And within the U.S., it's actually 1.4. It has been 1.4. Now, of course, if you look globally, this, again, is from an older publication, and I've not seen it put together this nicely. The high-income countries have 16% of the population in '94 and spent 89% of all health spending. That's even more powerful than the 80-20 rule, which says in any country at any time, 20% of the population will account for 80% of all health spending. But that has to do with the fact that these people are sick and the others aren't. Here it has to do with the fact that these people are poor and therefore cannot afford health spending. The rest of the world has 84% of the population, and in '94 spent 11%. It is probably even lower now because ours went up so much. You see, global health spending then was $2.3 trillion. U.S. health spending today is $2.1 trillion. So it gives you some idea how much we grew. So the takeaway here is healthcare is a superior good, and on which proportionately more will be spent as GDP per capita rises. And the developed countries accounting for less, well, I've told you that. That's a summary. Now, if you look in the U.S. and you plot per capita health spending deflated from 65 to 2003, you get this very nice trend line, and this little coefficient says in a very long haul, the American health system has extracted from the rest of society 4.5% more money per man, woman, and child in real dollar than the year before. That was broken, this trend, by managed care in the 90s, sort of about 5 years. Managed care really did arrest that trend a little bit, but then the health system regrouped, saw the enemy, defeated it roundly, and is now on that old growth path again. If you extrapolate that, I went here to the year 2100. Now, you may say that's just ridiculous. Why would an egghead do this? Well, for one, it's easy. Once you have the equation in there, you just push the button and you go. But secondly, I'm not nearly as ridiculous as the august trustees of Medicare and Social Security Fund who project to infinity and discount it back and tell us how much we owe. So while I'm vaguely ridiculous, I'm not as ridiculous as the trustees. What it says that by the year 2050, if nothing happens, close to 40% of GDP will go to healthcare. Now, you could say the GDP, of course, will be fairly big too at that time. And the question is, would we ever do it? And we might, if in return the health system says we're going to get rid of Alzheimer's, cancer, and we make a Viagra pill that lasts 50 years, which, of course, we would then need. And for that, we might do the deal, for all you know. So to an economist, the issue is not the percent of GDP, but what are we getting for this? And there are some questions. The takeaway here is if these trends continue, a lot of people say healthcare in the U.S. is not sustainable. Actually, one could say it probably still would be, except past 2030, we would actually have less of everything else than we now have. But we had a lot of health care. The way I always describe it, there'd be king-size beds from coast to coast made by Mitsubishi, 2 Americans in each bed with an MD degree giving each other checkups. The Indians would tabulate the bills and tell us what the GDP was, which is not impossible. I mean, this could be done, and we're crazy enough to do it. But something is probably going to happen, and I think one of them will be the smarter use of information technology in general and information. And here, Dr. McClellan was just exemplary. We've never had a leader of the Medicare program such as he, and we all cried tears when he left because he was beginning to put in place this information system, which I hope will continue. But we owe him a great deal of thanks. And incidentally, I would also add the information system he put in place for the Medicare Modernization Act was awesome, in spite of the fact that he got beaten up in the press. If you've ever used it, it's really quite amazing what that thing is able to do. And then the genomics revolution, should it ever come, because it's always sort of, it's the new technology around the block. I've heard that now for 15 years. So I'm learning today whether we can actually count on it. Playing around with economic incentives, it's just playing at the fringes. That won't solve our problem very much. Now, demographic trends are the other thing that'll drive a lot of health spending and what products we need. There is the aging of the population. These are the famous Notestein curves. Were they developed, James, at Princeton? I think so. Notestein? No? Anyway, this is just from a publication, but I saw the whole world is aging. The U.S. now in 2000 was 12.3% over 65, will be 21. But you look at Germany, it'll be 31. Sweden, 30. Italy, 35, because in spite of their reputation as great lovers, whatever they do, they don't make babies anymore. And the whole world is aging. It's now about 7% are over 65, and it'll be close to 20%. So this is a worldwide phenomenon. And it is well known. This is a tabulation 99 data, but normalized on 1, that is, let's call health spending with 34 to 44-year-olds 1, and then see what other age groups use. This is by paper Mayara, White, and Cutler. And you could see older people use 2, 3, up to 5 times as much health care than younger people do. So you might think, as we drift population-wise into that end of this curve, health spending should shoot up. And speech after speech, Mark, I don't know how often you've heard it, well, you know, health spending is shooting up, but it's aging that drives it. Now, any demographer knows that's probably unlikely, but it's a very popular thing. So if you write speeches for the CEOs, put that in, you'll be safe. Everyone will believe it. This shows you just, it's worldwide. These are German data for use of drugs and sundries. And again, it goes up by age. Now, the interesting thing, though, is when you look across the OECD and you put on the horizontal axis the percent of the population over age 65, and on the vertical, per capita health spending, or I could have health spending as a percent of GDP, I get this cluster of points. Now, Professor Trussell has always taught statistics at the Woodrow Wilson School, so in his honor, I ran a little regression equation, and here it is. So what this says, James, and we'll have you comment on it, is that as populations get older, they spend less on health care. That's, of course, pure garbage, but that's what bivariate regressions do. And I sometimes do that on a speaking circuit just to annoy people. The truth is there's almost no correlation there internationally. And when you ask, well, how would aging drive national health spending? Well, through the demand side, that, you know, these older people need more drugs, more hospital days, more physician visits, and you would think intuitively that really just must drive demand. And then there's the supply side. So if you look at the demand side, I recently had a paper in Health Affairs concluding, although it's not a trivial matter, population aging is nowhere near the strongest driver of the demand for health care in the United States or globally. It's really income that drives it. And I used some data that the Agency for Healthcare Quality Research has. Julie Hudson, I just told her what I'd like to simulate it, and she was kind enough to run it for me. And what it says is, between 2000 and 2030, when the baby boom retires, if only the aging, if that was the only variable that changed, population size, per capita utilization by age all stayed the same, aging explains half of the annual growth, half a percentage point of the annual growth for men, even less for women. I don't know why women are so cheap when they get older, but they are. And 0.39, say 0.4% for the population as a whole. And the reason is that most people plot graphs dishonestly. On the left, the axis goes from 12 to 22. I actually teach my students in freshman economics how to sift, how to structure information felicitously, meaning you take truthful information, structure it so that the beholder lies to him or herself. And that is what a good Princetonian should know to be successful in the world. But if you plot it the way we demand our freshmen do on the right, you can see there's no baby boom tsunami. There's a ripple. It's just not a big deal. You couldn't surf on that if you tried. So there was an older study done, published in the HICVA Review, what is now called CMS, and they simulated from 1990 to 2030. The red is the growth in health spending just due to aging, and the blue is all the other stuff. So aging is not that big a deal, per se. Although the kind of products you will make will, of course, vary. The music may be on the supply side more, where if you look at the trustees' report, they go to, again, to 2075. But we now have about 3.4 workers per elderly. That's supposed to go down to about 2. And I asked my colleagues in demography, what about immigration? Can't we solve it with that? But they pointed out to me that immigrants have a serious genetic flaw. They age too, and at some point they too will be in nursing homes demanding health care. So that can help only a little, unless immigration grew every year by very substantial numbers. Then we could probably bail out. So we'll have a shortage of nurses. That's okay for us. We'll steal them from Canada. The Canadians will steal them from England. The English will steal them from Ghana. And you have this migration now, and we sit at the top of that. So for us, it's not really a problem other than money. But that could drive health spending on a unit cost basis. A day in a hospital could be very expensive, given that in California, a critical care nurse already earns more than a pediatrician. That gives you some idea. So the aging per se is not a strong driver. It's more likely to drive up health spending through the pricing per unit of service. But here too, IT has to bail us out. We have to deliver health care more cheaply, wireless. I've seen technology now where people can just have a wristwatch on or just put their hand in a glove, elderly people at home, and somebody will monitor them. Medtronic already makes a device, I think Guidant too, that defibrillator that sends, right? They send out messages. So I think IT will solve some of the labor problem here. There is morbidity, and there you have a mixed message. Our colleague Burton Singer and somebody at Duke, I forget, showed that disability is actually declining by close to a percentage point every year. So there we have good news, but obesity and chronic disease associated and driven by obesity is becoming a problem which we sort of understand. 125 million Americans have one or more chronic conditions. Half of health spending is now actually due to chronic conditions in the U.S. And what, in general, almost everyone says, we're not doing that as efficiently as we could, chronic care. That's where the music is. And that's, again, IT has to help us solve this problem. There is on the CDC website, I didn't download them because there's so many slides, but they have a slideshow where every 2 years they show you obesity in the U.S. and you can click and it gets browner and browner and browner, and brown means more obese. But this is worldwide. We're just the heaviest, but you know, the French, everyone, even in China, people are now becoming obese. So that is now the map in 2005, particularly in the South, a lot of obesity that leads to diabetes and the attendant diseases. This is Ken Thorpe at Emory had this nice slide saying that severely obese people have a lot more multiple chronic conditions than people who are only obese. And of course, if you had people who are not obese, far fewer chronic conditions that are driven, and everyone pretty much knows that. So that is a trend that I believe will drive costs, and in a way it's extremely annoying because it should be completely avoidable. You cannot blame that on genetics because, you know, you can't, genetics doesn't drive these maps that I showed you. There is, in addition, a quest for global accountability where the people who pay for health care want to know. I think one of my fellow panelists will be from J&J Human Resources, who buys health care, actually, want some accountability. I give you some New Jersey numbers. These come from Jack Wenberg, and I asked him to run this for me. This is the inpatient cost per decedent Medicare in the last 2 years of life, the ratio of the New Jersey hospitals to average in the U.S. And you see St. Michael's 3 times as much per decedent did Medicare spend than the average for the U.S. Atlantic Medical Center in the same state, only 1.1. And he breaks it down in hospital days and reimbursement per day. And if you relate that to the CMS technical quality score, Mark, did you develop that?
I think that was thought too,
Based on, yeah. When you plot it, find me a correlation. I dare not even draw a trend line through this one, or Professor Trussell will give me an F. But there seems to be no correlation. And so I think, see, the traditional model of healthcare was that the doctor and patient decide to do something. There was an outcome. Someone got billed. They paid it without question. And no one ever doubted that their doctor was the best in the world. So why even worry about outcome? That's the old 20th century model. We'll have that in New Jersey another 10 years. But California is already far removed from that. They're moving more into this model. Doctor and patient still do decide on a plan of action, but they're monitored. They have guidelines on what they should do. Outcomes are monitored, fed back to the doctors, fed back ultimately to consumers. Used to be called patients, call them consumers now. That is the 21st century model of healthcare, accountability for outcome and cost. And eventually, and this is what Mark was doing, pay for performance. If the performance outcome per dollar of spending isn't adequate, you get paid less. Or my wife would prefer no performance, no pay at all. But she's pretty brutal. Well, traditionally it's been P for P is pay for pulse. It has been, if your pulse was active, you got paid. And that's gone. So IT will drive this model. Sorry for the typo there. There's a global quest to engage users of healthcare. Some people call them consumers. I still rebel against that. I would still either call them users or patients, because there isn't really yet a healthcare consumer. Unless you were to say somebody blindfolded, you move them into Lord & Taylor's and say go shopping. If you call them a consumer, then yeah, we're consumers. But that's where we now are. And in theory, of course, consumerism can take two forms. One is what I call consumerism, is information on nutrition, alternative medicine, health behavior, information that helps you manage your health care better as a person. And the other one is information that helps you to buy health care more prudently. If you share in costs, that you minimize your costs, or at least you pick hospitals that don't kill you. And that is all yet coming, but this is called consumer-directed healthcare. In the U.S., that is meant to connote high deductibles. But the Canadians would tell you, no, you can have consumer-directed healthcare with zero deductible just by giving information to patients on which hospital has better outcomes, which doctors have better outcomes, and so forth. So you don't need high deductibles for consumer-directed healthcare. I had this a very busy slide. I used that in a talk recently in Washington. Just the yellow boxes is what I want to focus on, is patients need information on managing their own health. There has to be information to support that. There has to be some information to decide when do I go to the doctor and when I don't. I have some symptoms, and I'd like to get some information on the web. Is this likely to be serious? Once I had a stubbed toenail, and I like to annoy my wife, who is more medical prone than me, and I said, I have melanoma in my toenail. It was about 1 a.m. in the morning. And she says, oh yes, there's such a thing. I don't know what it's called. I said, so doctor in the house here. There is, in fact, melanoma under the toenail, very deadly, because you don't put suntan lotion there. She scared the hell out of me. So I was on the web till 3 a.m. I knew for sure I had it. By that time, I knew. And I went all the way. I said, book you, pen. I'm going to have a complete checkup of my toe. I damn near had the toenail ripped off. The information can also be very disadvantageous and make you consume more health care than you should. It was about an $800 visit, of which we paid a lot. Diagnostic decision, doctor says, I need to operate. Well, do you really? You need that kind of information. And then also decision information to make you comply with drug regimens, which is a huge problem in the U.S. People just don't do what the doctor told them to do, and there should be wireless reminder, you ought to go take your medicine. All this will come, I think. Of course, all of that information can be tapped, downloaded by strangers. Diskettes are lost, like happens all the time, and that raises issues of privacy and equity, which we'll discuss. Genomics, as I said, I once listened to a talk of Francis Collins, and as he was talking, I drew a sketch, and I want to let it all hang out. What he said, and I don't know if it ever happened, is genomics should help you to target drug R&D better, because many times when you actually discard a drug, it only affects a certain genotype, but not all of them. Some patients benefit and others get killed. So if you could target that better, you should be able not only to do faster research, more targeted, but a lot of discarded drugs you could take off the shelf and have another look. I don't know if that ever happened. Maybe someone will tell me. Customized prospective health maintenance by genotype. Now that is, I'm a trustee of Duke University, incidentally. I'm missing the board meeting over this, which we have weighty issues, lacrosse and stuff like that. So I regret, but this was more important. We do this at Duke, where you have a 5-year health plan worked out with patients and a 1-year plan. We do, of course, it's preventive care. You can treat diseases, target much better your diagnosis and the treatment, and all of this we'll hear about: gene therapy, customized pharmacogenomically targeted drug therapy of patients. All of that I heard in Francis Collins' talk, and I made this slide. I think, Lee, you will walk us through all this. I thought this is about 5 to 10 years in the future. Some of it, though, we already have. We have markers for breast cancer and others that are used at Duke. And what I hope this will do is, here's that line that I projected, and what we look for, genomics and IT, is to pull that line down, catch stuff earlier, where instead of treating sick people, you treat probabilities of getting sick of seemingly healthy people. A totally different paradigm of treating people is to get them when they're healthy and make predictions about their likelihood of getting this or that cancer, and then having health plans to lower those probabilities. That is the dream. This will cost more in the short run, and I hope we have the wisdom to invest in it, because when you build aircraft, the first few aircraft are more expensive than the latter, and this will be true with genomics as well. But the idea is, this is the model. This is Ralph Snyderman's slide. He gave that to me. You intervene personal lifestyles. You modify the risks through behavior. Some people that can eat meat and others you better not. And we hope to be able to target the health plans this way. And if it's late in the stage, still do chronic disease management, which I think Mark may tell us is only now beginning, but we have a lot of hope for. And as I said, we actually, John Mack gave us $50 million, and his wife, actually, Christy, gave us $50 million to build a building. To actually have it, it's there. We are actually doing this now, enrolling people. But Mark wouldn't pay for it, so we have to figure out. Our insurance model is not set up to do this, because, why would Aetna pay for this when the payoff comes to Humana 10 years later? Ideally, you would like to have life cycle insurance so that somebody has an interest in paying for this early to avoid illness later, as we do in prenatal care for HMOs. Medicaid HMOs give first-rate prenatal care because the payoff is 9 months, and you have the payoff. This is the model. I don't want to walk you through, but I'm just telling you it is there, and at the core of it is actually genetic markers, which we are hoping to develop more and more. And Lee, maybe you guys can help us with that. J&J, incidentally, is a partner in this with us on this model. So naturally, this model raises all the technical and ethical issues that we will explore at this forum. So let me end on this point and turn it over to the experts.